Next is about prameha. Athata pramehanidana व्याख्यास्यामः यथोवाच भगवान् दिवास्वप्न व्यायाम आलस्य प्रसक्तं शीतस्निग्ध मधुर मेद्य द्रव्यान्नपान सेविनं पुरुषं जानीयात प्रमेही भविष्यति इति. A person who has a tendency to sleep during the daytime and who doesn't do rigorous exercise and who is always lethargic and who tends to eat more of the Shita Snigdha Madhura and Medya. Medya is something which increases Medodhatu. And Dravanapan, liquid consumption. So your food habits, your lifestyle is the factor which predicts about the possibility of the prameha. So it's a primarily lifestyle disorder. तस्य देव एवं प्रवृत्तस्य अपरिपक्वाः एव वातपित्तश्लेष्माणो यदा मेधसा सह एकत्वमुपेत्य मूत्रबाह्यस्रोतांसि अनुसृत्य अधो गत्वा बस्तेः मुखम् आश्रित्य निर्भिद्यन्ते तदा प्रमेहान् जनयन्ति. When the vitiated doshas, due to these kinds of life habit, involving the kapha doshas, vatapitta kapha doshas, and affects the medodhatu. Now, medodhatu, what it is, another controversial issue. Many people say that Medas is the fat, but I don't agree with that. The Medas is the fat. But Medodhatu, the functions of the Medodhatu are related to the fluid and electrolyte balance. So, more of that part, like whether it is a fluid and electrolyte balance or not, part of that we have discussed in the beginning when we discussed about the Dhatu in Sutrasthana. Or again, we will have some more space for discussion in this issue when we go into the Sharirasthana later. So for the present, we will consider that Medodhatu represents the fluid and electrolyte balance along with whatever you consider as a fat. Saha ekatvam upetya, it affects that fluid and electrolyte mechanisms and it results in involvement of the mutravahi srotamsi anusritya adho gatva bastehe mukhamashitya nirbhidyante tada pramehan janayanti. Prameha are produced due to the involvement of the fluid and electrolyte mechanisms and related to the lifestyle. And there are two important issues, prameha and mutrakritsha. Part of that we have referred to that when we discussed about the Ashmari in the previous chapters. Then again, the mutrakritsha and mutraghata are related to the urinary collecting system, the duct. Whereas in case of prameha, they are the nephrologic, related to the formation of the urine. So the diseases related to the formation of the urine and the content of the urine, where the content of the urine would be presented as either abnormality of the quantity or the quality. Prabhuta avila mutrata. Prabhuta, where the quantity is either increased or reduced, or avila, where the consistency or the appearance of the urine has been affected. That kind of the disease are called as prameha. So, in the present day situation, nephrological disorders can be considered as prameha, whereas the urological disorders are the mutrakritsha and mutragata. During that period of Sushruta, and in some of the texts, it is often referred to as the pramehas tend to occur in males only, but not in females. But Sushruta doesn't agree. रजप्रसेकात् नारीणां मासि मासि विशुद्धति सर्वं शरीरं दोषाश्च न प्रमेहन्ति अतः स्त्रियः इति. Certain textbooks would say that the females would not have prameha because they would have some amount of the blood getting out of the body which results in a shodhana and hence they may not have the prameha. But Sushruta doesn't agree. Etattu na yuktam sarvatantra aprasiddhehe pratyaksha virodhacha, because it's not accepted by all and because it is directly seen that prameha occurs in females too. So according to Sushruta, prameha occurs in the females too. Now, when we say the formation of the urine, now there are two important aspects. The one aspect of the formation of the urine is a passive filtration which occurs at the glomerulus. The final duct system or the part is the whole structure of the nephron. Nephron would have a glomerulus, proximal convoluted tubule, loop of Henle, distal convoluted tubule, and then collecting duct. The formation of the urine would have many aspects. The first aspect is in the glomerulus, where there is a passive diffusion. The blood vessels which are in the glomerular tuft, they would have that membrane, glomerular membrane, acts as a permeable membrane, and it allows the substances to pass through and tries to maintain that concentration of the fluid which is formed at the glomerulus, that glomerular filtrate, and the plasma would be same. And the glomerular filtrate rate of that filtration occurring in the glomerulus is one of the important criteria of assessing the renal functions. We'll come to that part later. Glomerular filtration rate, or GFR, is one of the important criteria to assess the function of the kidneys as such. Now, the quantity of the fluid formed here is much more than the real ultimate final outcome of the urine. It's around 16 to 20 times more than that. That's if at all you are excreting 1 liter of urine, almost around 16 to 20 liters of glomerular filtrate is formed at the glomerulus. And as it passes through the proximal, and the concentration of the electrolytes, concentration of the substances would be almost equal to that of the plasma. Only the substances which have a molecular size bigger than that of the glomerular membrane would be filtered in, like a fat tissue, heavy proteins, they are filtered and they are not allowed to come in. But the substances with a lower molecular weight, irrespective of their contents, including glucose, would be flown in or would be present in the glomerular filtrate. Concentration of the glucose in the glomerular filtrate and the plasma is almost equal. But by the time the fluid passes through the proximal convoluted tubule, a good amount of these substances are reabsorbed, which are essential for the body. Now, I will not go into that detail, like which of the substances are absorbed and so on, but there will be a reabsorption, or some of the substances are actively secreted, like maybe the phenolphthalein, like heavy molecular substances which are not filtered in the glomerulus, they are excreted selectively, actively at the proximal convoluted tubule as well as loop of Henle. In the loop of Henle, there is a portal system. The blood vessels would have a portal system. There will be a distribution of the capillaries around that loop of Henle, and this distribution of the capillaries around the loop of Henle helps in maintenance of the concentration of all the substances, toxic substances, metabolic substances, as well as the electrolytes. They are concentrated, and in the distal tubule, the primary function is a reabsorption of the fluid. Reabsorption of the fluid, where ultimate and the electrolytes also reabsorbed, and the quantity of that filtrate would be reduced to the requirement as that of the body, and the whole of this is regulated by a complex mechanism of maintenance of sufficient concentration of the fluid in the body. Now, I will not go into detail of these further, but from our dosha point of view, the majority of the functions which are in the glomerulus, they are related to the kapha. The functions of the loop of Henle and the proximal convoluted tubule, they are to a great extent related to the pitta, where there is energy utilization, and the specific substances are absorbed or excreted. In the distal convoluted tubule, it is about concentration of the urine, where the content becomes reduced and it becomes more concentrated. That's the function of vata. So majority of the diseases related to the prameha, vata, pitta, kapha, to a great extent, not all, can be related to the glomerular functions in case of the kaphaja, and the pittaja prameha conditions to a great extent related to the tubular pathology. So tubular disorders of the kidney, they are related to that. The concentration ability of the kidney is related to vata. This is how we can, to a great extent, can make out. Now, tesham the pururupani, the pururupa of prameha, before the prameha would occur, the clinical symptoms which can be seen are hasta pada daladaha, snigdha pichila guruta gatranam, madhura shukla mutrata, tandra, sadaha, pipasa, durgandashta, shwasa talu dala jihvat deshu, malopattihi, jatiki bhavakeshanam, dudhishchanakanam. Now, whenever the pururupa of any disease is mentioned in our samhitas, many of them now in the present day situation may be considered as a complication, later events. That's the criteria to make a diagnosis of a disease now and in Sushrutas period, or maybe or Samhita period, would be different. See, in Samhita period, only when there is a visible clinical signs of the prameha, then you will make the diagnosis. Of course, in case of the prameha, Sushruta says, at the end you will come to that part also. Even if there is a few symptoms, but there are certain triggering factors or lifestyle is supportive, then even you have to make the diagnosis of prameha. So that point where you make the diagnosis of prameha based upon the pratyatma lakshana, that's a prabhuta avila mutrata, may be comparatively as per the present diagnosis. In the present diagnosis, because you have lots of biochemical instruments, technologies, you may diagnose the abnormalities of the urine content or urine formation earlier. As in case of the, if at all you take the example of diabetes mellitus, you can identify that the patient has diabetes by looking, assessing the sugar level in the plasma. Diabetes insipidus, you can specific gravity before the clinical symptoms do occur. So hence, certain of those clinical symptoms which are considered as Purva of Sushruta may be, in the present day situation, may be seen as a complication, like Hastrapada, burning sensation or altered sensation in the feet, which are now considered as a later complication of the prameha. I don't say only diabetes mellitus. In the diabetes mellitus, it is well known peripheral neuritis. Many of the renal diseases also would present with the similar symptoms. And stick the picture of Guruta Gatrana Mudra Shuklamutrata, the abnormality seen on the surface of the body, it could be like edema or maybe the pitting edema or weight gain, the Guruta Gatrana, weight gain also could be a clinical symptom. Again, in the present day situation, may consider as a complication of the renal pathology or later stages of the renal pathology. A weight gain and visible edema will be seen in a chronic kidney disease only after stage 3. Up to stage 3, it will not be seen, whereas Sushruta had considered this as a Purva. Now, this kind of a difference of opinion does exist, and it has to be seen by the looking at the point of making the diagnosis in the present day situation and the earlier days. And Pipasa and Madhura Shuklamutrata. Now, when I say Madhura Shuklamutrata, not necessarily that it should be about diabetes mellitus, it could be about altered contents of the urine. That's it. And the general debility and a lethargic feeling, Durgandhasya Shwasatahu, a foul smell in the air breathed out as well as in the oral cavity. And excess of the secretions of the body, both urine as well as sweat, also being more. Jatili Bhava Keshanam Ruddhishchanakanam, the hairs become bundled out and the nails grow faster in case of prameha. Now, these are the need to be reviewed or maybe studied. At present, we do not have any such evidence like renal pathology would result in a increased growth of the nail as per the text. But it is observed many of the patients would say that they have that kind of a nail growth faster in case of diabetes mellitus. I have seen that. But an objective study, objective survey of this kind is not really made out and can be a good field for research in future, which can be substantiated. It's not yet substantiated by objective means, but it's I think there is sufficient scope. तत्र आविल प्रभुतमूत्रलक्षणाः सर्वैव प्रमेयाः भवन्ति. That's what I just said. And sarvadoshatsmuttah sahapidakadihi. Though you have the categorization of Vataja, Pittaja, Kapaja, Prameha, all the Pramehas would have involvement of all the diseases. Now, for example, as I told you about, when we say a chronic kidney stage, we consider this diagnosis of the kidney stage, disease by staging and by identifying at that with the technological tools where even the patient may not have a clinical symptom. Up to the stage 1 to 3, you may not have a clinical symptom at all. And it's only when the patient would reach the stage of clinical stage 3A, you may have some clinical symptoms as such. Till then, there will not be any clinical symptoms. And we make the diagnosis of stage 1 by looking at the glomerular filtrate, not by the clinical signs. There will be no clinical signs at all. And another quite important is diseases of the kidney are difficult to be managed, particularly chronic kidney disease, which we at the later it can result in a kidney failure, would be difficult to be identified even with the biochemical means. The biochemical means like creatinine and urine level, which is urea level, which are considered as the standard benchmark for the diagnosis, may not be possible to be used for diagnosis at an early stage. If at all you have to identify a kidney disease in early stage, it has to be GFR, glomerular filtrate rate, which has to be considered. And if it is less than 90 milliliter per minute, then we consider it as a stage 1 disease. And usually in the stage 1 disease, glomerular filtrate rate may be even slightly more than normal. At times it could be more than normal. And the reduction from 90 to 60 to 89 is seen in case of the stage 2. So in the stage 1, glomerular filtrate rate may be slightly more than normal, and hence again it will be quite difficult to look at that. The creatinine level is not a criteria to diagnose the early condition because kidney has a maximum reserve capacity. Reserve capacity of the kidney is around 20, and in the sense 1/19th of the total kidney mass would be enough to maintain the normal biochemical functions of the body. And hence, till about 95% of the kidney is damaged, the creatinine level may not raise. So if the creatinine level has raised, it means more than 90% of the kidney is already damaged and you have only 5 to 10% of the kidney left over in the body. And that would be quite late in the diagnosis. So if the renal function tests like creatinine level has been increased, it suggests that you have reached up to a level of maybe 3 or 4, beyond 3 or 4 of a kidney disease, and is tending to have a kidney failure. So that's why in the nomenclature now you have two nomenclature: chronic kidney disease and chronic kidney failure. So kidney failure is when the glomerular filtrate rate is less than 15 ml and the patient is on dialysis. Patient needs dialysis, that's considered as a kidney failure. And in the early stages, it's considered as the kidney disease with the stages. And this is the criteria to make the diagnosis. And when you have this kind of a criteria, and when Sushruta says Prabhuta Avila Mutrada as a Pratyatma Lakshana for the criteria, naturally there will be a huge gap in making the diagnosis. And this gap may give you some confusion at times, but I think that confusion need not be there. We have to keep this in mind. Then these pramehas are named according to their clinical symptoms and based upon the dosha environment. Tatra kafat udaka ikshuvaalika sura sikata shanehi lavana pishta sandra shukra prameha dashasadhyaha. 10 pramehas are kafaja and they are sadhya. They are relatively easy to be cured. Dosha samakriyatvat, because the treatment for dosha as well as dosha are the same. Pitta, when the pitta has involved, it results in 6 types of the prameha, and those are Nila, Haridra, Amla, Kshara, Manjishta, Shonirameha, Shatyapyaha, Doshanam, Kshamakriyatvata. Then Vataja, they are in Krishasadya, Pitta are Krishasadya. Vataja, Sarpi, Vasak, Shaudra, Hastimeha, Chatvaraha, the 4 varieties, Sarpi, Vasak, Shaudra, Hastimeha, and Asadhyatamaha. Mahatyikatvat, because they tend to produce more complications. So grading in the present day situation would be of the stage 1 to 4, whereas from Samhita point of view, grading will be depending upon environment of doshas, kapaja, then the pittaja, then the vataja. Vataja would be suggestive of the failure, where virtually you cannot do anything. Asadhya. Vata pitta medo bhi anita shleshma pramehanjaneti. Vataki kapha shonita medo bhi anitam pittam pitta pramehana. Kapha pitta vasa majja medo bhi anita vayu vata pramehana. So when the doshas are involved, particularly vata pitta and medas are involved in the kapha, it produces the kapaja prameha. Vata pitta kapha shonita rakta also is involved in with the medas, then it's the pitta prameha. Kapha, Pitta, Vasa, Majja, Medas, all the more of the dhatus are involved that produces a Vata Prameha. This again shows the same like environment of more and more of the systems. Now going into individual varieties of the Prameha. The first of them is Udakameha. Tatra Shvetam, Avedanam, Udaka Sadrisham, Udakamehi Mehati. Udakameha is a condition where the content of the urine would be close to that of water. Now, one of those important criteria in the clinical practice is the specific gravity. A specific gravity in a normal urine would be more than 1.01. Now, specific gravity is defined as a comparison of the gravity of water and electrolyte, any of the substance, ratio of that gravity into to that of the gravity of the urine water, and water would be 1.00. In case of a normal urine content, when the kidney has a capacity to concentrate, the concentrating ability of the kidney would make the specific gravity about 1.01. When the specific gravity is less than 1.01, or very specifically 1.005 or less than that, or is very close to that of the water, or the osmolarity is less than 200 milliosmolarity, that means if the concentration capacity of the kidney is reduced, it's suggestive of the udakameha. That's considered as a diabetes insipidus. And this capacity of concentration is mainly regulated by antidiuretic hormone, which is this pituitary hormone, a pituitary hormone which mainly acts upon the distal convoluted tubule to facilitate the reabsorption, and if the reabsorption is not there, then it can result in what we call as a diabetes insipidus. Diabetes insipidus again are now categorized into four categories based upon the pathology, either as central or nephrogenic or dipsogenic, or it could be gestational. Now, central condition is where there is a definite reduction of the ADH, the pituitary abnormality. The pituitary, posterior pituitary is not able to produce that. Nephrogenic is the ADH concentration is normal, but the kidney tissue is not able to respond. In case of the dysogenic is abnormality related to the permeability of the tubules, where otherwise the kidney tissue is normal. Only the threshold of the this thirst center is altered. So because the person takes more water, and that more water results in more excretion of the water, and that results in a dilute urine, which also may be considered as a diabetes insipidus. And are patients who have a abnormal vasopressinase. Vasopressin is the substance which is also the other name for ADH. Now, that vasopressin is destroyed earlier, that condition could be gestational, where there is a genetic tendency. Now, I would consider the central and nephrogenic pathologies as something related to the pitta dosha, whereas the kafaja udakameha is primarily about the dysogenic and gestational, because they are relatively earlier and relatively easy to be cured. And in case of dysogenic, regulation of single water consumption would be often enough, and you don't need to give many specific treatment. Behavior therapy would be enough. In this gestational, it's about the pregnancy. That usually you by you maintain the water intake, regulate the water intake, the condition can be managed. Whereas the central and nephrogenic conditions are difficult to be managed, which need supplementing of vasopressin. So that's how the importance. So Udaka Meha, I will consider as a diabetes insipidus, particularly dysogenic and gestational. Then the Ikshurasa, I would Ikshurasa Tulyam Ikshuvalika Meha. Ikshuvalika Meha would be a condition where the person would be excreting a sugar cane like urine. Now, when I say sugar cane like urine, is it about the color or is it about the property, the taste asset? I would say it's about the sugar present in the urine, like diabetes mellitus. Now, diabetes mellitus type 2, you have two varieties, type 1, type 2. Type 2 diabetes mellitus obviously has all the clinical signs of a kapha prameha, and is characterized by the excretion of the sugar in the urine, glucose in the urine, and hence I would consider type 2 diabetes as a Ikshuvarikamya. Type 1 maybe it may be considered as a there may be Vata Prameha, some variety of Vata Prameha, the other way, the point like Kshaudra for the Vata Prameha, maybe that way. The popular notion of naming that diabetes mellitus as a Madhumeha is not clinically justified. So I am not saying that's wrong or so on. I will not use that word wrong. But it's not clinically justified because Madhumeha, the diabetes mellitus which we see in majority of the conditions, type 2, they resemble that of a kapha because of obesity and the excess of consumption of the calories which results in. Now, mechanism of maintenance of the glucose in the blood and the urine would be, in any condition, the glomerular filtrate would be will be filtering the glucose, and the concentration would be almost same as that of the plasma. But by the time it reaches the proximal convoluted, this loop of Henle, all the glucose will be absorbed, provided the concentration of the glucose is within the capacity or the threshold limit of the kidney. So if the kidney has a normal threshold limit and the glucose which is present in the filtrate is within that limits as such, then all that glucose will be reabsorbed, and the urine which is formed reaching to the distal convoluted tubule would not have the glucose at all. But if at all, the glucose concentration in the glomerular filtrate is more than the capacity of the threshold of the kidney, or if the threshold of the kidney tissue is reduced due to any factors, then there could be a glucose present in the urine, and it results in the excretion of the glucose. So, two factors which can result in glycosuria or glucosuria would be either it could be increased glucose level in the plasma, or it could be reduced to renal threshold level. So, it's not that every patient who has a glucosuria is diabetic. Diabetes mellitus is not a finalized or ultimate diagnosis is not based upon the urinary glucose level. So, diabetes mellitus, the primary pathology is the quantity of the glucose in the concentration of the glucose in the plasma is more than the capacity of the kidney, and hence there is a glycosuria. But once there is a glucose concentration in the urine which is in the distal convoluted tubule, it will be producing more osmotic pressure, and hence the water absorption will be less. Rather, there could be this secretion of the water, and hence it results in the polyuria. Quantity of the urine also would be increased. So, quantity of the urine increased in case of a glycosuria condition is a indirect effect of the presence of the glucose in the distal convoluted tubule, where the concentration would not be possible. So, the mechanism of formation of that the glycosuria has to be clearly understood, and they have to be differentiated from the diabetes mellitus as well as the other way, the renal threshold conditions. I would consider the diabetes mellitus of type 2, where the obesity, excess of consumption of calorie is the primary cause, and that would be as the Ikshvalika Meha as such. Then the conditions like Sura Meha and the Lavana Meha. Sura Tulyam, Sura Mehi, Vishadam, Lavana Tulyam, Lavana Mehi. In these two conditions, Sura is the alcoholic, where there will be a fermented smell which is characteristic of the acidic urine, and Lavana Tulyam, it's something like Lavana, that's where if you touch the urine, it will be soapy like, you will not have that sticky feeling. That's the alkaline urine. Now, conditions where alkaline urine and acidic urine can occur could be many. If the patient has a renal tubular acidosis, consumption of alkaline drugs, consumption of diuretics, urinary tract infections, some of them urinary tract infections can produce acidic urine, some may be alkaline urine. Vomiting and metabolic pathologies or respiratory acidosis also can result in an alkaline urine. The pH of the urine may be raised, whereas pH of the urine could be reduced as acidic urine could be produced due to dehydration, drugs which produce acidification like ammonium chloride, with fever, gouts, diabetes. Diabetes also can produce a acidic urine, pH may be reduced, and a high protein diet, pulmonary emphysema, where carbon dioxide concentration in the plasma can be more, can result in acidic urine. So, acidic or alkaline urine, Surameha or Lavanameha, may have to be identified or may have to be investigated properly to identify the cause. They may not be categorized as nephrogenic conditions or nephrological conditions in the present day situation, but pH assessment of the urine can give you a clear idea about the real cause, and hence it could be considered as one of the variety of the prameha. Then the crystalluria, patients who have conditions where there will be pain and passage of the crystals. Sarujam sikatanuvidham sikatamehi. There will be sikata is sand particle like substances passing through. Now crystalluria again can be produced due to many conditions. And again, it could be either as acidic pH crystals or alkaline pH crystals. In both the conditions, when the pH of the urine has been altered, acidic or alkaline urine has resulted, one of the complications could be the stone formation or crystal formation, which can later result in Ashmari, the stones also. And in case of the Ashmari, we have discussed that issue, like whether the crystals have to be considered as a complication of the stone or they have to be the prodromal. In the present day situation, it's the prodromal. Crystal area is one of the predicting factors about the possibility of the stone formation. So that's the point. Now, when the crystals are seen in the urine, it also depends upon the pH which decide about the source of the crystal. Mainly calcium oxalate, uric acid, and urate crystals, leucine crystals, tyrosine and cysteine crystals, they are presented in acidic pH, whereas alkaline pH, it would be resulting in phosphate. Either it could be amorphous or triple phosphate or carbonate, occasionally calcium carbonate, rarely biurate crystals could be formed. Then the Shanirmiha, Shani Sakapam Mrusnam Shanirmihi, Mrusnam where it becomes thick and it has the appearance of something like the juice of the food. Cup and Sakapam, there will be cup also. It's now can be seen as chyluria. Chyluria is where the lymphatic duct or lymph opens, lymphatic fluid is excreted with the urine. Now, it can occur due to one mechanical injuries or where there is a bypass between the cisterna chyli and the bladder, as in case of a surgical post-operative complications, many of the abdominal surgeries, thoracic aneurysms which may rupture, or neoplastic conditions, malignancy where again there could be tissue loss, and then it can result in the passage of or obstruction to the lymphatic duct, and then it can result in the passage of the chyle into the or lymph into the urine. In addition to that, the other factors a patient presenting with the chyluria, you need to get investigation. Investigations like to rule out filariasis, another common cause for the chyluria in our area is the infective pathologies like filariasis, which is common, or the non-filarial infections like malaria, echinococcus also can result in the same. And then the non-parasitic conditions like tuberculosis also can result in the same. Post-nephrectomy and patients like nephrotic syndrome or hyperglyceridemia. Now, patients who have a high triglyceride level also can result in chyluria occasionally. So, the more important is chyluria is not considered as a single disease entity. It could be suggestive of many of the other diseases. Most important is mechanical, where there is a leakage. Then the Hristroma pisarastulium pistamihi, when the fluid, the urine excreted is looking like a liquid prepared out of the floor pista, that's the phosphaturia. You can see that kind of a crystal, maybe formation of a partially insoluble substances, the phosphates in the urine. Very often you see this in the patients who are on catheterization or who are bedridden for a long time. That is quite common. The other causes of the phosphaturia are, other than that, the bedridden conditions and the bone metabolism being altered, calcium phosphate metabolism being altered. The other causes are hyperparathyroidism or patients who have genetic conditions with the rickets like conditions, linked, X-linked rickets, or patients who have a continuous fluid administration, volume expansion, and the total volume of the circulating fluid has been increased. Diseases of the renal tubules, patients who are on diabetic or metabolic acidosis also can result in phosphaturia. The most important and most common cause is patients who do not do exercise, who are bedridden and who are on catheterization. Then Sandrameha is where the specific gravity of the urine is increased. Agilam Sandram Sandramehi. Sandra is the specific gravity has increased. Specific gravity is increased mainly when there is a leakage of protein. Now, proteinuria are patients who have that protein in the urine. The most common cause of the proteinuria is the glomerular damage. If the glomerulus is not capable of retaining the protein. Now, when in the beginning I told you, glomerulus would be retaining the protein because the pore size of the glomerulus would be smaller than the molecular size of the albumin or any of the other proteins, and hence it retains the protein. But if there is a glomerular damage, then the protein can leak out, and that's what we call as the glomerular proteinuria, which we call as the nephrotic syndrome. See, there are two conditions, nephrotic syndrome and tubular nephritis. Now, in a nephrotic syndrome, the proteinuria will be there, and that proteinuria is produced with the glomerular damage. It's also called as glomerulonephritis. Usually, the quantity of the protein in the urine will be quite high in that condition, and when you examine the urine, you will have grade 4 or grade 3 like the protein content, albumin content. Whereas tubular proteinuria is the other way, where there is a damage to the kidney tissue, and usually in the chronic kidney disease. In the chronic kidney disease, like diabetic pathology, diabetic complication, nephropathy, there the quantity of the protein usually is smaller, and it continues to that. Many times it will be microalbuminuria. The quantity is so small that it may not be identified with the routine examination. You will have to collect 24 hours of urine and then see. And then, of course, in the later stages, it can result in more involvement, and it can result in a renal failure. In the tubular proteinuria, it's not only the protein loss which is important, there could be other metabolic pathologies too, so you need to investigate the other factors also and then confirm. So, primarily, the most two important conditions are the glomerular proteinuria and tubular proteinuria. The other two, which are not so important, are overload proteinuria, where due to excess of the protein present in the body, either it could be consumption or it could be some abnormality related to the liver functions, and the total albumin level may be raised. It can result in overload proteinuria, clinically less important. And the postrenal proteinuria is where there is some inflammation of the kidney and or bleeding or maybe malignancy of the kidney system. The proteins may be added to the urine after the formation of the urine in the kidney. Clinically, these two are not so important. Clinically, the first two, glomerular and tubular, are the more important, and they can be considered as the Sandramaya. The causes again, to, as I told you, if more detailed, would be the causes for the proteinuria could be many. It could be the tubular diseases or renal diseases like glomerular disease, which again can be produced due to immune factors, amyloidosis, diabetic nephropathy, hypertension, preeclampsia, and rigorous exercise, dehydration, toxic substances, or orthostatic also. Whereas the postrenal causes are lower urinary infections, menstrual contamination, vaginal secretion, etc. Microalbuminuria, very characteristic of diabetic nephropathy, which is also a tubular pathology. So this way, any patient with proteinuria is to be investigated, and the exact causes have to be made out. Though we consider them as Sandramaya, that's not the end of it. You need to investigate further and make out the diagnosis. Then Shukratulyam Shukramehi, when a patient passes Shukra or semen with the urine. Now this is mainly in retrograde pathology. Retrograde ejaculation is often produced due to a structural defect that the seminal vesicles would have a connection into the bladder directly, which otherwise in a normal situation ejaculation would be into the urethra. A urine contaminated with the semen may be possible immediately after the ejaculation. If at all you collect the urine sample immediately after the ejaculation, some residual portions of that leftover may be seen, but that is not consistent. Whereas in case of a retrograde ejaculation, it's consistent. Retrograde ejaculation, we have referred to that issue when we discussed about the Shukrashmani. Again, of course, we have certain issue. It doesn't result in a visible semen, but it can be seen only in the urine, and the major issue would be about the infertility of that patient, not the other way. Then, Phenomeha is a condition where patient would have stokam saphenam acham phenomehi bhavati mehati. Phenomeha is a condition where the lipid would be present in the urine and the consistency will be more. Now, the phenomeha and the shanirmeha, like in the case of vataliprameha, we will come to that part, they have a similar issue. In both the conditions, the quantity of the urine excreted would be relatively small at every micturition. The frequency would be increased, and it will be very thick and foamy. That foamy is produced due to the fat content in the urine. Presence of the fat content in the urine is always suggestive of a destruction of the nephrons. The tubular, maybe glomerulus, as well as nephrons, they are destroyed. cause could be many, damage could be many. It could be due to autoimmune conditions, it could be due to infective conditions, it could be a sign of nephrotic this failure. Usually, a presence of the lipid in the urine is always considered as a poor prognosis and suggestive of a possible renal failure. Concentration of these would be the different factors. When the concentration is lesser, it could be a kapha prameha. When the concentration is more, it's a vatya prameha as a shanir. We'll come to that part again later. Pitta nimittan, the next is a pittaja variety. Pittaja are atavurdun pittaja nimittan व्याख्या समाह सफेदम अच्छम नीलमिहि mehati. When the urine color has tendency to become a bluish or dark is seen, it's the nilameha is often seen in hemoglobinuria. Patients who have hemoglobinuria, often it can result in the nilameha, that's the bluish color. One of the common condition is a nocturnal paroxysmal hemoglobinuria, which is often related to the genetic pathology, and it is seen in a large number of people. Global incidence is about 1 to 2% per million individuals as such. So 0.001% would be the usual prevalence. And the exact causes are not known, and they may be that paroxysmal nocturnal hemoglobinuria may be presented as anemia or thrombosis or maybe fatigue or smooth muscle abnormalities, dystonia. The tone of the smooth muscles will be lesser. These are the other clinical presentation, comparatively less common conditions. The hemoglobinuria also can occur due to burns, crushing injuries, or certain renal diseases, rarely the other diseases. The characteristically the urine will be bluish or blackish color. It's usually the blackish color. The kala azar, the other infected is leishmaniasis. There again, there is a possibility of hemoglobinuria, and the disease is named as kala azar in Bengali because of that kala, the black color urine is the other feature like. Then in the picture, Sadaham Haritramehi. Haritrameha is where the urine is a dark yellow color. Now, yellow color in the urine very commonly seen due to the presence of urobilinogen in the urine. So, normal urine also would have urobilinogen, which gives that yellow color. Now, if the concentration of the urobilinogen is more, then it can also result in the darker color of the yellow urine. The yellow urine, yellow color having much darker than the usual yellow. So when we say the color yellow, normally the urine would have some amount of the urobilinogen which gives yellow color. It can be increased without any pathology if the total concentration of the urine is more, water content is lesser. If you have, if you have consumed water lesser and then the urine is passed, it may have more than usual yellow. The other reason is when the metabolism of bilinogen is altered. Now, based upon the normal metabolism would be the bilinogen would be converted into bilirubin and in the liver, and then it's excreted. That urobilinogen would be added, excreted into the gastrointestinal tract. From there, it is again reaching to the kidney. Some amount of that urobilinogen would be present in the fecal material too. So certain would be, it will be oxidized and it undergoes enterohepatic circulation. I don't say that a patient who has a increased urobilinogen always has a jaundice. Of course, it commonly it's considered as a sign of the jaundice. But even in the patients who may have a normal liver function, urobilinogen concentration could be increased if there is a hemolysis, if there is more of urobilinogen formation, and hence it needs to be investigated, and that's considered as a haridramya. Then amla rasagandham amlamehi, where you will have a sour smell as well as sour taste. Now, smell of the urine is one of the important characters, important issue. In the clinical practice, though it's not regularly used, it's often considered as a criteria. A urine which is having a very foul smell is often a sign of UTI, urinary infections. Many times that smell could be identified based upon the organism which is presented. The ammoniacal smell is produced due to Pseudomonas or Proteus, where it will have a irritant smell, and because these organisms they produce more ammonia, you will have the ammoniacal smell. The other foul smell could be produced due to other gram-negative organisms. So that's one. In ketoacidosis, there could be a fruity smell, a burnt sugar level, burnt sugar-like smell, is seen in maple syrup urine disorder, which is also a genetic pathology, a rare condition. But the important is the smell of the urine also is a criteria to make the diagnosis. Though the taste may not be a practice. Sushil has referred to the rasa, amla rasa, gandha amla mehi. So tasting the urine is also a criteria of making the diagnosis in Sushil's period. Now we may not do that. That's the other point. Then Sudha Kshara Pratimam Kshaраmehi. Kshaраmeha is where the urine would look like Kshara Jala. That's where there will be no absolute no stickiness. It can be produced due to multiple conditions. That Kshaраmeha could be produced due to where the urine consistency is altered, could be produced due to multiple factors like chyluria, pyelidiasis, schistosomiasis, arthur surgery, malignancy, and so on. The pH of the urine could be altered and it can have that soapy feeling. So that content soapy feeling and the water, the urine would be having less sticky material. The patients may identify, but it may not be suggestive of a single disease entity. All that what you have to do is clinically you need to confirm the basic pathology by thorough investigation. Possibilities are many. That's all the important issue. Then Manjisthodaka Prakasham Manjistha Mehi, a urine which would have a color of the Manjistha Jala, somewhat purple or orange, dark orange color. It's a very characteristic in case of the parphyluria. Parphyluria is another clinical emergency. It can present with usually acute abdominal symptoms and the dark colored urine. And the causes for that, triggering factors for the parphyluria is usually genetic pathology, but it can be triggered due to either lead intoxication or arsenic intoxication, alcohol intoxication, having liver disorders, or it may end up in liver disorders, or it could be presenting with the anemia. So, and acute abdominal emergencies like acute abdomen symptoms could occur. So that's about the parphyluria, which is though not common. Occasionally you may see such patients. And many times wrong diagnosis of appendicitis and appendicectomy done in parphyluria can result in calamities. So every patient of acute abdomen, it's quite important to know about the color of the urine and if necessary, go for the investigations. Then Shonita Prakasham, Shonita Mehi Mehadi, when the patient passes the blood either visible or not directly visible. When it is visible, we call it as a hematuria. When it is not visible, seen only under the microscope, it is called as occult hematuria, or it's also called as a microhematuria. In another way, the hematuria also can be classified based upon the source, either extraglomerular or it could be the glomerular. When it is extraglomerular, that means beyond the glomerulus, somewhere in the collecting portions of the kidney, the color would be red or pink, that color of the blood would be seen. When it is glomerular, at the glomerulus level that the blood has been added to the kidney or urine, then it tends to have a smoky brown or something like Coca-Cola color. Then clots are usually present in the extraglomerular, in the lower area. Then again, the shape of the clot also would be quite important. If the bleeding is from the ureters, then the clot would be presenting as a nodule or noodle-like appearance. Whereas if the bleeding is in the bladder, the clot would be irregular shape. And then in case of the glomerular pathology, usually it's always presented in the this proteinuria with the larger quantities of protein, whereas glomerular conditions, the quantity of protein in case of extraglomerular would be lesser, whereas in case of glomerular, the protein would be more. RBC shape seen under the microscope in case of extraglomerular, the shape may be normal, whereas in the glomerular, the shape would be abnormal. In the extraglomerular, again, the source could be either from the tubules, there could be a malignancy or polycystic kidney, or maybe the abnormalities related to any of the other abnormalities related to the ureter. Stones are the other important causes for the extraglomerular bleeding. And the blood will be passing. Ureters also, again, it could be tumors, stones, and it could be strictures also. Infections also can be. Bladder, again, malignant or benign tumors of the bladder, infection could be caused. Even there could be bleeding from the prostate or the urethra. Now, when a patient presents the hematuria, the quite important would be you have to take the history about whether the hematuria is more in the beginning of the micturition or at the end of the micturition, or maybe somewhere, whether the concentration of the blood is uniform throughout. The general rule, which is also called as three tube test, is you have to collect the urine in three tubes in the beginning of the micturition, middle flow, and end of the flow, and compare the color of the blood. If it is a beyond the bladder, if the bleeding is beyond the bladder, like urethra or so on, then the bleeding would be more in the beginning. If it is in the bladder, within the bladder, the bleeding will be more at the end of the micturition as the bladder contracts. If it is above the bladder, proximal to the bladder, ureter or kidney, then the concentration of the blood in the urine would be uniform throughout. All the three tubes would have the same color. This is one of the very frequent clinical tests done and quite having importance. That's about the Pittaja variety of prameha. The next is Vataja prameha. We will continue in the next session. We will continue the Vataja prameha and then some more issues in the next session and complete. Today we will wind up because the time is up. If there are any questions, we will try to answer. Like there are many questions. Uh, In clinical practice, how will you diagnose the earlier stage of the kidney disease other than GFR? So that's exactly the criteria. It's only the glomerular filtrate rate which makes the diagnosis, early diagnosis. Otherwise, you will be making the diagnosis only after stage 3. Before stage 3, if you do not have a glomerular filtrate rate facility, diagnosis of a renal disease is not possible. So if you make the diagnosis of renal failure or chronic disease in the clinical, based upon clinical criteria, it will be always above stage 3, stage 3A. Then another question is, what is the difference between Sharkara Meha and Sharkara mentioned in the Ashmari? Now, I would consider this as a Sharkara Meha is a habitual, where there is a everyday or regularly the patient passes the crystals. Occasional crystalluria may be considered as the Sharkara of a complication of the Ashmari. Or it could be the other way, a patient who have a metabolic pathology, it could be the Sharkara Meha, when the crystals are broken, as in Ashmari it is mentioned, the Ashmari being broken and the crystals are passing through, it's the Ashmari variety, a Sharkara of the Ashmari. Then the understanding of the Kshara may be mere as alkaline urine or much more. Okay, that's true. It could be beyond that. But one of the easiest possible explanation would be the alkaline, where it has the same property as the. I don't say Kshara is alkali, but Kshara would have a feature which looks like the liquid of alkaline substance, where it will be having a soapy appearance. So from that point of view, I consider this as the alkaline, not necessarily that it should be alkaline urine. Then Sikata Meha, which could be the crystalluria. If crystals are alkaline, then would be Kshara indicated. Now, of course, in Ashmari Chikitsa, of course, we will have some discussion about this in the Ashmari Chikitsa, when Kshara also is indicated in the Ashmari. That part we will have that in the Chikitsa chapter. Now, whether you have to use these alkaline substances or acidic substances in the crystalluria, from the present day's point of view, it has to be based upon what we see in the biochemical factors and selection of the drugs. I would be dealing with that when we deal with the Chikitsa. I think so. We can have some scope for that discussion when we discuss about Chikitsa, right? Okay. Uh, Thank you, sir. Right. We'll conclude today. Right.